원장님 안녕하세요.
Greetings.
네,
Greetings.
반갑습니다. 이번 주제가 Bravo My Digital, Bravo My
The
Life.
title of this session is Bravo My Digital, Bravo My Life. When I first heard this topic, I really looked forward to today's session. One of the reasons is because as a dentist, you are naturally very sensitive to different ongoings of digital dentistry, and it has vast impact on communication with the patient. Before we begin, I'd like to ask you a question. How has digital dentistry changed your life as a dentist? I prepared for this presentation and I remembered a novel. I thought of a novel by French Voltaire during the Age of Enlightenment. Candide and the people around him looked back on life in the novel. In the last part of the novel, an old man said, "We have gone through a lot to reach here. It has never been harder than now because we are bored now." So boredom can be a big problem in our life. Nietzsche said an interesting phrase: boredom is something that even the gods cannot fight. So it almost happened to me, the boredom. I think digital dentistry made me overcome the boredom as a dentist. So it was a new, fresh breath of air. So what is the obvious boredom that a dentist can experience? Maybe it is the same treatment over a long period of time without changes. The obvious unsolved clinical problems that we are faced with, the same complaints from patients, excuses for the unsolved problems. So, using digital dentistry, how can we overcome boredom? This is what I prepared. Dr. Pe? Dr. Hall, you really are a true master in digital dentistry. Thank you for your input. Compared to Dr. Hall, I have much shorter clinical experience. Despite this, by accessing digital dentistry, I believe I've become a much happier dentist. I wanted to give you this comment. Dr. Hall, you said you overcame clinical boredom using digital dentistry. What is clinical boredom? And how did digital dentistry help you overcome it? There are about 6 items. The significance of digital dentistry. First, freedom from clinical ambiguity. Second, we can make the impossible in analog way possible with digital approach. Third, in almost all treatment, we can do the treatment within the set time. It's predictable. Fourth, more highly sophisticated treatment planning and implementation can be done with digital dentistry. Fifth, we can perform minimally invasive surgical and prosthetic procedure. Last but not least, as a digital practitioner, I can say we can do meaningful work instead of meaningless labor. Dr. Beth? So I have opened my practice in 2014, and in 2017 I bought my first 3D printer and stepped into the world of digital dentistry. Today, I have been doing my practice for 9 years, and I have been using digital dentistry for 6 years. This is the Facebook post at the end of 2017 when I first started digital dentistry, that by doing digital dentistry I can control all crown designs, but you can see that the time point is 2:15 a.m. I'm quite used to going home late because since my residency, but this makes it quite difficult to tell other people that digital dentistry is very good. In the beginning, it may be exciting, but if you go home late every single day, it can become even more difficult after having introduced a digital dentistry. In this situation, can you really say that you're a happy dentist? Personally, I am very happy. I would like to tell you my story so that you can learn from my past mistakes.
네, 그렇군요. 오늘 두 분의 이야기를 함께 하시면
I look forward to listening in your input,
그 디지털 덴티스트리의 참
and I believe that we'll be able to understand the true meaning of digital dentistry. Now let's dive in.
우리 배정희 원장님부터.
Dr. Baek?
사실 우리 목표는
Digital dentistry is actually not a goal, it's a tool, as a means to improve productivity and to make our lives more comfortable and to become a happier clinician. It's very difficult to define happiness. I've mentioned a short working time, but for some people, it may be happy to work long hours or to put more effort. For instance, after I started doing zirconia prosthesis, I thought the coloring was quite boring. I only use multi-layer block. I understand that Dr. Hall uses coloring and does a lot of CAD work. However, things can't be right if it's costing more money, energy, and time. You're more exhausted to even play with your kids after having introduced a digital dentistry. So I'm going to show you how I do my digital dentistry. What is digital dentistry? Everyone thinks of CAD/CAM, but in large sense, it is any dental technology or device that incorporates digital or computer-controlled components. This is from an article. In narrow sense, it's CAD/CAM, but digital radiography, digital photography are also included in digital dentistry. Electronic medical records are a very important factor. You can encompass not just patient records, but a lot of different data. Occlusal gauge device, dental laser, latest surgical tools, caries diagnosis, machine matching, the one-type painless anesthesia can all be included in digital dentistry. The category is also from the article. I personally use everything except for the laser here. Digital dentistry, you acquire digital data using input devices, process the data, and then reproduce prosthesis or outputs. I use this to communicate with my team members and patient and utilize data to do business management. So it can be divided into 3 categories: acquisition, processing, and usage. So with time, different data becomes accumulated and integrated, leading to new information. After that, it becomes a cycle. You accumulate and process and use these information. Let me show you my dental clinic. In my dental clinic, we do not use any paper chart, including patient consent form. I acquire and process patient data here. If you look at the latest electronic chart, you can integrate CAD/CAM data, digital radiography, and photography, and all other digital data. I do not use X-ray viewer separately. If you look at this image footage, it immediately is inserted within the chart along with patient and date information. If you look at Osstem, so one click, one photo, which is an electronic chart,
you can easily send images from tablet and DSLR camera to chart. I'm sure you've all experienced this, but when you take photo, it is very difficult to find the right patient and the case because there are so many. However, if you combine the electronic chart and wireless transfer of camera, patient and date information is automatically saved, and if necessary, different information can be tagged very easily. Image management and information management becomes much more easier compared with analog ways. Also, it's much easier to compared with just using digital camera. If you look at the chart, there's images, radiographic images, and scan programs can be connected to send patient information to the scan program. The scan results can be included in the chart as thumbnails, and viewer pops up when you double-click. If you integrate data, there are many benefits, and in 3Shape, a platform called Unite has been initiated, and they're trying to integrate 3Shape software in this platform. I believe the platform that integrates digital data will become the electronic chart. Because I take a lot of images, I use it for patient communication, and if necessary, I take images and print it out to hand it to the patient. Scanners can be used for prosthesis fabrication as well as patient communication. It's wireless, so the patient can look into the monitor as I scan. Digital occlusal force gauge. It can be used for treatment as well as patient communication. The occlusal force gauge is not directly related to linked to electronic chart, but you can use it as screenshots to continue to monitor the changes in occlusal force. In terms of interior aesthetic consultation, you can integrate facial scan and oral scan to do consultation. This has become quite widespread. If you have lab, you can take a screenshot of cat's image and insert it in the chart to say that prepping is insufficient and that antagonist needs more prepping. Additional tools, it's very interesting. In digital dental clinic, you can clean using robots. If Osstem can integrate electronic chart with hospital management platform and use IoT, perhaps it can make a very smart dental clinic. There's like smart homes available these days, not just electronic vacuum cleaners. I believe the way we manage lights, door locks, water, heat, air conditioning, CCTV with computers or cell phones, or in other words, a smart dental clinic will come true with Osstem's technology. Digital dentistry encompasses CAD/CAM, digital radiography, photography, electronic chart, and everything else. And information is acquired, processed, and used in different areas. Because of the characteristic of digital data, it can be acquired easily. Once it starts to accumulate, you can get synergetic effect to provide a new information or evidence leading to a treatment plan that was not previously thought of before. I'm talking about a private practice. If this becomes a bigger scale, you can accumulate even bigger amounts of data, and this will become big data and become the basis for AI training, leading to even more possibilities. Which category do you think is what I've talked about thus far? You may not really relate, but it's really fun for me. Can you relate? So people find happiness in different areas, and I believe, Dr. Bae, you really enjoy being a dentist.
What about Dr. Ha? Dr. Bae talked about happiness, and overcoming the boredom would be in line with this. What do you think? Dr. Bae talked about advantages of using digital dentistry other than clinical matter, but I'm going to talk about how clinical activities of dentists can be enriched with the digital dentistry. First, we can be free from clinical ambiguity. This patient at number 17 and 47, discomfort, and there's many lacerations and cracks in the teeth, and for the problems, model-list approach is used. Number 17, after sintering, it can be polished, but it was stained too. So the most posterior teeth were delivered, and the patient is satisfied. But the patient said the teeth look good, but I can't really chew well, and the form of the tooth is changed. If you look at the crown form, I don't think there is any weird thing. Maybe the patient is too sensitive. But if you look at the CAD program, and I compared it to before treatment, cusp and central fossa were quite curved before the treatment. So when we do crown design, we need to recover the original crown form as much as possible because of this. So the prep was modified. The center of the teeth was reduced relatively less. So the crown was remade and delivered. And the full zirconia crown was satisfactory for the patient in function and aesthetics. So when a patient complains of discomfort, it is hard to identify the problem. But if you use the CAD program and if you analyze the pre-treatment situation, in many cases we can identify the cause. Second, we can make the impossible with analog approach possible with the digital dentistry. So the patient had an 8-unit long bridge in the anterior region. Abutments began to break down, and eventually I tried to make the bridge alive, but eventually the most posterior abutment broke down. So we had to take out the abutments. It should be treated from the start. The old prosthesis looked like this. So it looked like a denture to cover the horizontal or vertical defect. It was used for a long time, and the patient doesn't want a denture, and the patient wanted a fixed prosthesis. So I wasn't confident whether I can address the problem. If you look at the defect, there is a huge horizontal and vertical deficiency. The patient wanted a fixed implant prosthesis and not a denture. Can it be done? Here, various angles of the upper opposing tooth axis in red. With analog approach, the flap is raised and implants can be placed. Usually, it can be placed here, close to the top of lower ridge, according to normal treatment. If it is placed in the place marked with yellow, there's a huge horizontal positional deficiency. So denture-like denture-type prosthesis, like before the treatment, is the only option. So what if fixed prosthesis for lower jaw is designed first and in a top-down fashion? Implant positions are determined. Normal form prosthesis can be made possible. So for this, a guide is needed using digital dentistry. A guide is needed to place an implant, not at the top of the ridge, but at the slope of anterior and inferior side of the ridge. One guide, digital technology, is required for ideal positioning of implants. So the flap is raised, and using a guide, the implants were placed. Final prosthesis. The implants were placed driven by prosthesis. A fixed type prosthesis were made possible. So it was impossible with the analog approach for the surgery, but it was possible thanks to digital approach. So in many cases, digital guided surgery approach is very meaningful. The third benefit of using digital dentistry, we can always treat within the set time. For various reasons, treatment time gets longer because we need to check preparation margin if there is an undercut issue or if there is insufficient tooth reduction, retention form, and gingival cord would cause bleeding, and controlling bleeding takes time, and other issues make treatment time longer. With digital technology, these issues can be addressed. This is my clinic. All three of them are prosthetic treatment requiring patients. It doesn't happen all the time, but unexpected prosthetic patients can come, and many patients that need prosthetic treatment without digital, it can become very chaotic. So we can treat the patients in an unexpected situation like this very smoothly. Thank you.
Thank you. I can really relate to your case. Digital dentistry has really affected dentist's life in so many ways, and it's opening new doors. Dr. Pei, I'm sure you've looked at Dr. Ha's case, and I understand that you use CAD/CAM very actively. Since adopting CAD/CAM, what changes did you experience? Thank you. I use CAD/CAM a lot. Rather than case, I'm going to tell you my story. So I'm sure you're sleepy, some of you, I can see. Do you want me to sing? Let me show you my equipments for fabrication. As for scanner, I use Trios 3 and 4, model scanner and facial scanner. And for CAD program, 3 shapes, a dental system, and implant studio is used. For fabricating device, I use 5-axis dry milling machine and 3D printer. I've spent approximately 200 million won. If you look at my equipment, you'll notice immediately, but I use primarily zirconia and PMMA prosthesis. I outsource metal and ceramic restorations, including custom abutments. I bite down on the urge to buy more equipment to fabricate even more diverse types of restorations several times a day. To briefly show you the productivity of CAD/CAM these days, I don't make provisionals manually. If possible, I only do milling, or I use 3D printer. The patient only waits about 20 to 40 minutes. For zirconia, I provide a day later because if the patient's waiting, I feel pressured. As for custom abutment, including parcel delivery time, it takes about 3 days. As for surgical guides with fewer units, it takes about 10 minutes, and in total, it takes about 15 minutes. And regardless of the implant, I use Osstem implant most, but I only place implants using one guide. In the case of full mouth implant provisional, in the past I would take impression and make bite. It would take 2 to 3 weeks, but now, from design to fabrication, it only takes 4 hours. After CAD/CAM, it is difficult to really assess ROI. It's been about 5-6 years, and I've made approximately 2,500 surgical guides in my dental clinic. And STL file, I think I've done about 15,000. I believe the amount of restorations I've made sufficiently offset the initial purchase cost. So I kind of stinge on buying equipments. If you buy a lot of equipments, you'll be over budget very soon. In the beginning, I would do lab work myself, so I went home 2 to 3 a.m. Now I have trained one lab technician, and I only design surgical guide. At times it gets really late. I'm going to talk about productivity. And if you really get accustomed to it, within a short period of time, you can provide quality prosthesis with less stress quicker to the patient. And this can directly lead to more profit and ultimately more happiness as a dentist. Dr. Hall, I'm sure you relate to Dr. Bae as well.
The treatment workflow using digital dentistry is very efficient beyond imagination. Let me continue. So I would like to talk about the remaining 3 things. The fourth change the digital dentistry brings about is highly sophisticated treatment planning and implementation. Ortho department referred the patient to us. This is a single crown case, and everybody may think that's something we can do well. But a lot of things need to consider for this patient. To place implants, if you analyze the ideal crown positioning should be made, and we need to think about the implant positions. The implant should be palatally placed considerably, not at the center of the ridge. And if implant is to be placed properly, the implant should be placed should be deeper mesially than distally. If you place the implant on a similar height in terms of mesial and distal bone height, there is a high probability that implant can touch the root of adjacent tooth. So unless you position implant very accurately, the implant may touch the root of adjacent tooth, and the mucosa is very thin. And if it is shallowly placed, a lot of problems can occur when you do prosthetics. But if you use a guide to place an implant, the guide is designed, and with the brackets, the implants can be placed. Then the mesial and distal positions can be different, and the sinus lift can be done, and the biologic width can be secured, and the implant can be placed deeper. If you place implants properly, prosthetics can be done very good. So digital analysis is a must for that. 5, digital technology can enable minimally invasive surgical and prosthetic procedures. Especially for a guide, there is a misunderstanding. The guide is for beginners who are inexperienced in surgeries. I majored in perio, so I had the same bias. But based on my experience, there are so many limitations that they cannot be overcome without a guide. On all the patients close to 80, upper left posterior bridge needs to be removed for implant placement. As the patient is old, the principle is that we need to reduce the treatment time as much as possible. An implant component and the gap between that and bone or soft tissue should be reduced, and the scope of surgery should be reduced. For guided placement, number 24 and 25 implants were placed, number 27 as well. And sinus lift is necessary for 26. So crystal approach is a little bit difficult. So lateral approach is planned for sinus lift. So how can we do the lateral approach? 24 and 27, crystal approach is used to place implant with the bone graft, and the flap is designed starting from the distal of the upper left second premolar. The implant will be placed at number 26 after sinus bone graft. So using lateral approach, sinus bone graft was performed before placing an implant at the second premolar. Before finishing the surgery, sinus lift and 3 implants were placed between implant and tissue. There's hardly any gap. So the detailed implant planning was enabled by a digital guide. At 3 months, scan bodies were connected and oral scanning was done. Model-less abutment crown were designed at the same time, and using model-less process, centering, polishing, final prostheses were completed. So when they were delivered in the mouth, size, form, overjet, overbite, all the problems were resolved using a model-less approach. So final prosthesis, the whole process of implant placement, sinus bone graft prosthesis, we tried to make it less invasive, and it led to very good outcome. Well begun is half done, according to a medium. Who said that? And I searched. Aristotle said before Christ. The beginning is a half of the whole. When you start a war appropriately, you can achieve victory. But when it comes to implant placement, well begun is not just a half, but almost all. So at number 12, peri-implantitis is severe, so implant must be removed. What is the reason? It's an improper implant position. That made the prosthesis look like this, a very weird looking prosthesis. So cleansability is not possible. So that was the problem, the improper implant positions leading to peri-implantitis. So if you use a guide, such problems can be overcome. So the implant is removed, and you can see a big bone defect, and the bone graft and suturing was done at 4 months. According to the plan, using a guide, a flapless surgery was done at about 3 months. The further guided implant surgery was done. It was scanned with the scan bodies. Abutments and crowns were designed at the same time with the CAD in a model-less way. Individual abutments and the temporary teeth were connected. And rather than going directly to final case, PMMA or 3D printer should be used to get the feedback from the patient before final. So based on the feedback from the patient, the design was partially modified. A stain was added to the gingiva in the final prosthesis. It was designed considering aesthetics, functions, and cleansability. So that starts from the digital analysis of implant placement. Lastly, let me talk about the meaningful work instead of meaningless labor using digital dentistry. So we can focus on more meaningful work, mentally and physically. So this is common prosthetic approaches. We took impressions like that with open tray, and the dentists, lab technicians, and patients had to go through exhausting process. So I did this case a long time ago, and just by looking at it, it gives me a headache. With the digital dentistry, we can be free from such tiresome activities. With the digital dentistry, we can go away from such labors. So we can more focus on key problems. And then surgery prosthesis.
말씀을 듣는 동안에 저는 그동안 어떻게 임상을 적용해서 했는지 돌아보게 되었습니다. 저 또한 체어 타임을 이제 오버하게 만드는 여러 가지
So there are many factors that prolong the chair time, and within the set period of treatment, we need to finish the treatment. And I also thought about how much I enjoy the treatment and how much I have contributed to development. Do you agree? So Dr. Pei is going to talk about his cases.
Dr. Ha, thank you for the wonderful case. I'm going to show you my topic in line with Dr. Ha's fourth topic. In order to help you understand, I brought a scene from a movie Interstellar. You've seen it. Dr. Ha, did you see it? This is when the main character of Interstellar falls into the black hole, where there are three-dimensional spaces reflecting different moments in the character's life, and the character goes to the desired time and exchanges information using gravity. It's very easy. Maybe it's a bit of a stretch, in the sense that it moves between prostheses. I've named it Interstellar. In doing anterior implant restoration where aesthetics matter, you in general follow this timeline, and in this case, in number 11, immediate implant placement was done, provisionalization was provided, and it was adjusted several times before final prosthesis was delivered. If the aesthetic demands of a patient is difficult in terms of form, you need to go through trial and error to find the right provisional crown. You can use provisional crown that the patient was satisfied with in the end to fabricate the final crown. Let's superimpose different forms of restorations which were tried in different time points. You can see here that 5 different scans have been superimposed. Before extraction, immediate temporization, secondary temporization, third temporization, and final crown. When you superimpose, you can see that it becomes very easy to receive a feedback on different timeline. Or else you would have to use putty index if you were to use analog ways. You can compare prosthesis between different time points. That's why I've come to the name Interstellar. I'm not sure whether you can relate. Let me show you a more difficult case. In the case of a dentalist patient, you start off with no information on interarch relation or dental arrangement. You can scan, but it's impossible to get bite. You can use a wax rim to get bite, and once you scan it, you can get the 3 common landmarks between these scans. The landmarks that are in common between wax rim bite and the upper and lower. You can align it. 3 scans have been integrated in 1 coordinates, and we can call this registration. You can use these coordinates to superimpose different prostheses to make a surgical guide. Using this wax rim, you can align teeth and reflecting the occlusal adjustment. You can try it in the patient's mouth, because we need to always verify. If it is satisfactory, you can do implant planning. The information included in the guide design is upper and lower scan file, teeth, dentition file, CT. 5 information can be seen in a glance. 5 different information.
그렇게 해서 이렇게 탑다운 방식으로
Top-down method is used to fabricate surgical guide and surgery is done. If the bone quality is good for immediate provisional, you need to take bite. It's difficult in this situation. In the past, you would use wax rim or denture and cut it and take bite, but it's very rough. However, in the case of digital dentistry, you'll be able to make new restorations using the interarch relation using the previous restoration. This is a scan before surgery. Wax rim was used to get the bite. Dentition was aligned. It was superimposed. On the left, it's a surgical guide. There are 3 common landmarks. And as for lower, it can be where it protrudes out. Different scan bites and different time points can be transferred. So this is quite similar to cross-mounting that has been explained in prosthodontic textbooks of older days. The articular setting of temporary prosthesis was transferred to final restoration. Even if you don't register bite right after surgery, you can transfer bite so that it has coherency with existing wax rim, teeth arrangement, and surgical guides. In summary, if you make 3 landmarks that are in common between different scans and align it, you can merge different prostheses and proceed forward. Transferring bites between existing and new restoration is also possible. All of this was impossible in the analog days or required significant amount of work. As for full mouth patients, when you move on to the prosthodontic phase, you need to make temporary multiple times to receive patient feedback and reflect it in the final restoration. From diagnostic wax up to the provisional, you need to continue to reflect the patient feedback. And we can make it so that it looks pretty. The provisional that we use in this stage is called a transitional restoration. As shown on the right, you can see that various transitional prostheses along with facial scans have been integrated, and this can be used to make a more of a perfect restoration. With digital data, you can integrate different data easily, and this can lead to new information, new treatment plan, and come up with different types of treatment method. In doing CAD, when doing complicated cases, the more mesh data you have and integrate, the easier it becomes. You need to align or register the mesh in line with the bite relation or positional relation. 3-point matching is done. As mentioned, you can utilize different prosthesis designs in one. You can integrate scans taken before extraction, before prep, and scan of existing prosthesis. You can also get information of transitional prosthesis, which you get feedback from. If you can mill or print at your dental clinic, you can fabricate provisional very swiftly and replace it with ease. If you send it to lab, it's going to be very cumbersome with sending and receiving. So it's very easy to receive feedback in this case. So I've talked about virtual cross-mounting. If you cannot take a bite, if necessary, you can use the original bite that was used. Not just mesh data, but if you integrate CT in the patient's interarch movement, lateral interference, lateral movement, if you integrate it to CAD, you'll be able to reproduce a virtual patient in a more dynamic way in the future. And based on my understanding, Dr. Park is working on this.
정말 잘 들었습니다.
Thank you. I still have some more comments to go.
긴장해서.
I'm quite nervous. So if you utilize some mesh data, provisional and mesh data from provisional scan and the patient feedback on complicated cases involving edentulous full arch rehabilitation, VD change, occlusal change, complicated aesthetic restoration cases, we'll get better insight and inspiration as well.
감사합니다.
Thank you.
두 분 원장님의 그런 소중한 경험담을 들었고요. 그 경험담 속에는 디지털 덴티스트
So we heard the valuable experiences of the two speakers, and we can shout out bravo to both of them. So the presentations were in harmony. So I believe it has been very helpful to all of you. So let's go to conclusion, Dr. He. Okay, conclusion. As a dentist, when we enjoy life, when we enjoy evening time, or if we have economically enjoyable. So if clinical practice is a succession of boredom, it would be very unfortunate for the patient and the dentist. With digital dentistry, we can get rid of the boredom in clinical practice in day-to-day life, not forever, but to a considerable degree, based on my experience. So, in summary, we can free from clinical ambiguity, and we can make the impossible with the analog approach possible. We can finish everything within the set time. Predictable treatment is enabled, and this helps for the management of the clinic. And the treatment planning can be done very precisely, accurately, and implemented like that. So it can be called a quantum jump in terms of accuracy of treatment planning and implementation. Minimally invasive surgical as well as prosthetic procedures. So minimally invasive throughout the treatment process. And our work can get away from meaningless labor to meaningful work. Not only dentists, but staff of the clinic can get away from taking impressions or any trivial work. I'm a periodontist, so I always try to buy the new edition of perio books. Recently, the famous periodontology book by Lindy, its 7th edition was published. I was surprised to see that there's no analog prosthesis approaches explained in the book. All implant prosthesis is explained using digital process. So the digital dentistry is not future. It is reality. It is upon us right now. This concludes my presentation. Thank you.
Thank you. Dr. Pei? So I wanted to give a word of advice in a very abstract subject. And I wanted to give you what it means. I'm not sure whether you related and really got the gist. I want to give a word of advice to those of you who are just getting ready to enter the digital dentistry world or who have just begun. You don't need to try too hard to be perfect. Don't try to do everything. Focus on things that what you can do, and don't spend too much money on buying equipments and tools. Learning curve is something that happens to everyone, and you cannot overcome that with buying equipments. You can do just zirconia or PMMA just like me. This is the most simple thing you can do. And if you don't feel comfortable doing complicated cases, just do simple cases. And doing full mouth cases at first, it may feel very difficult. When I do full mouth, I use 3 bridges, and I do anterior first and then move on to posterior area. If you don't know what to do, you can ask questions to people like me. You don't need to do everything by yourself. You can work with your team members, and if there's opportunity, you can hire a lab technician as well.
여러분 그 행복한 디지털 치과
So I hope you enjoy your digital dentistry. Thank you.
네, 감사합니다.
Thank you.
지금부터는 Q&A 시간을 가져보도록 하겠습니다.
Now we'll have
먼저
Q&A session.
채팅창에 남겨주신 질문인데요.
Let's look at some of the
상당히 많은
questions
질문들이
raised on the
들어왔지만
chat screen. There are a lot of
제가 어떤 걸 해야
questions.
될지 되게 당황스러운데요.
So I don't know which
그래도
question
정말
to
좋은 질문
start off with, but they're all very great questions.
수술 직후에
대- ID
즉시
대박나자.
로딩으로 제작을 할 경우 추후 잇몸 퇴축으로 인하여 이전에 제작했던 어버텀
So gingival recession may occur, and
어떻게 해야 하나요?
because of that, abutment can be remade. In order to reduce such cases, what do? I don't really prefer to use immediate loading. If immediate loading needs to be done with the digital dentistry, I think you need to take risk. The impression taking is much simpler than analog way. So stock abutment is used on the day of surgery, and after a month when healing is done, the temporary prosthesis can be modified, and ultimately after a certain period of healing, the stock abutments would be removed and replaced with customized abutments. Nickname Illum said, in the full case, right after placement, when immediate loading is done, PMMA do you use or do you custom abutment including shell? Do you do immediate loading with those? Can I clarify the question? So right after placement, in the full case, PMMA, the temporary, do you use stock abutment or custom abutment? Do you do immediate loading of the shell or?
So there's no set answer, clinically speaking. I do not do prefabricated prosthesis. Prefabricated prosthesis have error, and doing relining right after surgery, it's too much, and I just do provisional separately. I don't do prefabricated prosthesis. You would have to do relining. As for custom abutment, I place it after bone remodeling is somewhat done. As for transitional prosthesis, I use a separate abutment. Multi-unit abutment is used. Abutment height is very low, so you can do something similar to wax up. And once the form of transitional prosthesis is set, I make final prosthesis with it. Thank you for the wonderful answer. Good life.
So when we incorporate the digital equipment, if you are the only doctor in the clinic, what is the efficient way to incorporate the digital equipment? Basically, when you start with the digital dentistry, you need to start with the scanner. What I talked about, if you want to enjoy all those benefits, you need to have a certain degree of designing capability. You can use a lab or in-house lab to do prosthetics. Who does prosthetics is important. You need to check whether the prosthetics is what you want or not. You need to have discerning capability. In reality, like Dr. Pe, many doctors do designing, CAD/CAM, milling, and coloring. You cannot do all of those in your clinic. It's not possible. So a dentist and a dental lab needs to communicate better because you need to divide the labor. And in the interface, you need to have the capability of interpret whether the prosthetics is very satisfactory or not. Last question. TS and 대박나사 gave us the same question. Cross-arch prosthetics know-how and the inter-jaw relation need to be acquired with 3 landmarks or higher. So how do you do it? Can you repeat the question?
Cross-arch scan. When you get the occlusion, how do you do that using oral scanners? Digital lab work and analog lab work, you cannot avoid error. So my experience is not that long, but that's my opinion. You need to scan full mouth, and when you provide prosthesis, the error can occur in lab process, not just the scanning process. You need to just accept it, and you need to segment the case into smaller pieces. And when you do the scanning in different companies, there are different strategies. You need to understand the different strategies recommended by the company. 3-point matching. As for edentulous patient, ways will be solved, but you need to get the bite using wax rim. The way that I prefer is if there's a lot of flabby tissue and if surgical guide cannot be adapted and if there's slipping and shifting, I place 2 to 3 mini implants ahead. When you place it, you can place the surgical guide and you can minimize the deviation occurring from it right after surgery if the implants remain, and you can use that 3-point to match the 3 points between pre-op and post-op images. Or else you need to use other landmarks. As for immediate temporary, the fit may be okay, but you need to accept that you need to adjust occlusion significantly. Now we will open the floor for questions. Are there any questions? Please raise your hands. Can you please tell me your name? I'm Dr. Kim Hyun-jae. I really enjoyed your lecture. I'm an oral maxillosurgeon, so I've only thought about surgery, and I've used one guide thus far. When you do sinus lift and do lateral approach, when you open flap, and it takes a lot of time to put in and take out the guide. In that case, do you really need to use guide for short span or simple bridge? I think just doing freehand may reduce time. My second question, if you make a guide 3D directly, when you do sinus lateral approach, do you make guides in this case? Can you repeat the final question? When you do sinus lift, lateral approach, do you open flap, and on top of that, do you extend a little more using one guide? And do you use guide in that case? You open lateral window and then fit guide. I think that's too much, personally. As for your first question, routinely, do you need to use guide for that case? The design coming from one guide center or other guide centers or treatment plans, I didn't realize this at first, but the mesiodistal distance, it's really great, but buccolingual position, it may not be exactly matching with what I've thought, because they get the ideal crown position first, and they do top-down approach for implant placement. In a lot of cases, they do a rough job in aligning the crown, so if it's slightly buccally or lingually tilted, the guide placement position can be tilted. In final prosthodontic phase, the prosthesis, it may be it may not really reflect the antagonist relation. As for guide, I almost always use guide. However, I don't use guide for every single case. I don't use guide for drilling all the time. If the ridge is narrow, the drill can slip. And at times it can ruin the implant surgery itself. But the guide can provide a sense of where initial drilling and the depths. So it has meaning. I always design my guide, and based on that, and you can get good rough sense. As for your second question, you open second left sinus window. I don't think using guide is necessary. I've shown you my design. As you do a lot of digital dentistry, the flap design, you need to think outside of the box in terms of making incision. You need to be more creative in making incisions. You do not do mid-crestal incision. You can reflect the flap on the palatal side. But actually, you need to think outside the box and think which kind of incision would be best. You need to come up with your own incision. Did it answer your question? Thank you. It was a very sharp answer. Finally, we'll entertain one more question.
Would you identify yourself first? I'm running a lab. My name is Songdeok Park from Busan. We do all the work digitally. The trend is Highness or SPP, Harry Bio, screw retained custom. We are moving beyond those. But what about in your clinic? How do you link digital dentistry there? So any speaker can answer. In terms of the trend emerges because there's a need for change, or it's a matter of a preference. So final prosthesis, general custom abutment, and cement or ER type is what I prefer. Sometimes multi-unit prosthesis with many screws are used, but more conservatively, when you have many components or screws, mechanical problems can arise. So I still use cement type or ER type yet. In my case, my answer is the same as Dr. Beck. Cementless implant crown is made because of a cement problem. When you do CAD design, depending on the custom abutment design, we can avoid the excess cement. The cementless approach has the limitation. There's no problem in general prosthesis, but for aesthetic crown contouring, there's problems. As he said, the loads on the implants can be concentrated on screws, even though digitally the precise prosthetics are made. The cement can compensate some of the errors, but if you just rely on screws, the screws will get a lot of loads, so mechanical problems can occur, and there is no evidence of what will happen. So we need to be a little bit careful regarding. I agree with what Dr. Best said.